and today I'll be speaking about hip dysplasia. These are my disclosures, none of which are relevant. So interestingly, of the hip arthritis patients that we treat today, about 10% of those had some underlying dysplasia. Typically this is DDH, which is the most common presentation, and also the most common musculoskeletal diagnosis in newborns. We know when that happens, it can lead to instability, subluxation, or even irreversible dislocation. Unfortunately, a lot of these cases go missed or undertreated when early intervention is key, and so 10, 20, 30 years later, this case on the right is the one that may walk in your door. Fortunately, we have a nice classification system to help quantify the amount of subluxation. We can also get some clues as to whether we'll need any acetabular augmentation, typically needed when you have less than 60 to 70% cup coverage, or leg shortening osteotomy, typically needed when you need to lengthen at least 3 to 4 centimeters. So our standard workup is to get some weight-bearing functional x-rays. This will help demonstrate joint collapse, but also give us an idea of whether we have any issues with spinal pelvic mechanics. So I'm not going to overcomplicate this. The way that I do it, and the simplest way that I can think of doing it, is simply measuring the anterior pelvic plane on a standing lateral x-ray, a line drawn from your ASIS to your pubic symphysis, and deciding whether or not this is greater than 10 degrees. So why is this important? A good ratio to remember is 4:3. So for every 4 degrees of pelvic tilt that you get, you're going to get 3-degree change in your acetabular aneversion. So for example, if you put a cup at 25 degrees of aneversion, but the patient has 20 degrees of posterior tilt, you effectively place that cup at 40 degrees of aneversion. So this patient population